This presentation is over Parkinson's disease. My name is Denise Aziz, and this was recorded on September 4th, 2020. Typical patient presentation. Mr. Smith is a 66-year-old patient who presents to the outpatient neurology clinic with chronic symptoms of bradykinesia, stoop posture, mask-like expression, and dysphagia. He explains that when he gets out of bed in the morning, he feels very dizzy. It is difficult for him to pronounce words correctly, and he notices himself drooling at times. Over the past 8 months, he has noticed his symptoms becoming more severe. Etiology. The cause is unknown for Parkinson's disease. Possible contributing factors include genetics. About 10% of cases are hereditary, but it's rare to get the disease that way. Environmental factors include exposure to pesticides and herbicides. Those can affect the amount of dopamine produced in the brain. Now let's look at the top right corner of this slide. Parkinsonism can be divided into 2 categories, primary and secondary. Primary is when the cause is unknown, also known as idiopathic. Secondary Parkinsonism is when the cause is known, for example, environmental factors, exposure to pesticides and herbicides. Another would be head trauma or even drug intoxication. For example, we could say that farmers are at a greater risk of developing Parkinson's disease than, let's say, an accountant, because farmers are more exposed to chemicals and accountants aren't. Background. Let's look over some demographics. For new cases, there's about 60,000 per year. Mortality rate for males. Year 2000, 8.8 per 100,000 people. Year 2013, 11.0 per 100,000 people. For females, year 2000, 3.9 per 100,000 people, and year 2013, 4.8 per 100,000 people. So we can see here that the mortality rate for males is way higher than for females, because Parkinson's disease is also very common for males to develop it than females. Risk factors. For gender, men make up most of the cases of Parkinson's disease compared to women. The image to the right shows that women make up only 36.88% of the cases, whereas men make up 63.12% of the cases. For the age, individuals can develop it before the age of 40. That would be considered early onset. But it's more common amongst older aged individuals, usually after the age of 60. That would be considered late onset. And there's also juvenile Parkinson's. That is when individuals get Parkinson's disease before the age of 20. This line graph represents the age of onset. The y-axis shows the number of cases for Parkinson's disease. The x-axis shows the age at which people develop Parkinson's disease at age 35 and below. So it would be juvenile Parkinson's or young onset. That is where there's not many cases for the disease. The line starts to increase, and there is a peak at 55 through 59. So that would be the late onset cases. And the graph shows the decline after the age of 59. Pathophysiology. The part of the brain that is affected for Parkinson's disease patients is the basal ganglia. The basal ganglia lies within the midbrain. The specific part of the basal ganglia that is affected is the substantia nigra. In the substantia nigra, what is happening? Well, the neurons are being impaired. They're being depleted. And this is causing a decrease in the levels of dopamine and an increase in cholinergic activity. Cholinergic neurons, those secrete acetylcholine. And dopamine and acetylcholine are supposed to work together. But in Parkinson's disease patients, they're not working together. So one is affecting the other. And in normal, healthy individuals, we have control over our voluntary muscles. We can choose whether to contract, we can choose whether to relax. And they lose control over their body movements, so they can't control their voluntary muscles. The symptoms would be bradykinesia, akinesia, tremors, and rigidity. I will go more in depth of what those mean in the slides coming up. In the top left corner, that is showing a image of a healthy basal ganglia. The substantia nigra are the two black lines you see. They're dark in color because the neurons are healthy, they're not impaired. When you look at the image below, that's showing the difference. So we can see that the substantia nigra is fading away in color, and that just means that the neurons are dying and they're not secreting as much dopamine as they should. To the right, this just shows the image in more of a colorful way. So the normal substantia nigra is the two black lines, and the Parkinson's disease, the substantia nigra that's affected would be the two pinkish purple lines. Continuing on with pathophysiology, Lewy bodies start to form. Lewy bodies are found in neurons within the substantia nigra. They're made up of the alpha-synuclein proteins, and normally alpha-synuclein proteins are in a wave-like structure, but they form into Lewy bodies when they start wrapping around themselves and creating a clump-like structure. The image to the right shows the Lewy bodies. You can see those circles. Symptoms with Lewy body formation would be hallucinations, depression, and inability to sleep. These symptoms are common in dementia patients as well, and there is a type of dementia specifically known as Lewy body dementia. So there is a similarity between Parkinson's and Lewy body dementia because they both form Lewy bodies. There also could be depletion of cholinergic neurons, and those are responsible for releasing acetylcholine for contractions. Symptoms could be sensory impairment, olfaction, so they won't be able to smell as well and differentiate between odors. There could also be decreased levels of norepinephrine. Norepinephrine and adrenaline, they both work together for our flight and fight response. That is when our heart rate increases and our blood pressure, all those other things are starting to increase. And symptoms would be memory loss and depression. Symptoms could be motor or non-motor. Motor symptoms include bradykinesia. Brady means slow, kinesia means movement, so slowness of movement. Let's break down akinesia. A means not, without. Kinesia means movement, so absence of movement. They could also have tremors, that is the shakiness of their hand. Rigidity is the stiffening of their muscles. Dysarthria is when their speech muscles start to weaken, so they can't really speak as well as they used to. Dysphagia is when they have difficulty swallowing. Non-motor symptoms would be inability to sleep. Sensory impairment, specifically the sense of smell, hallucinations, depression, orthostatic hypotension. What that is when, let's say, for example, a patient gets up from bed, they're going to feel very dizzy because their blood pressure is dropping. And drooling. There is no known cause or pathophysiology behind the drooling, but strong research suggests that it's a result of bradykinesia. The image to the right shows someone with Parkinson's disease. They usually have a hunchback, so postural instability. At their wrists, they're going to have shakiness, so the lines in their pants is representing that, and they could also have rigidity in their feet too, so they'll often shuffle with their feet. When they walk, their steps are not really great in length. For the diagnosis, a physical examination will be done. That is to kind of cancel out the disorders that are showing symptoms similar to Parkinson's disease, and examples could be Lewy body. So Lewy body dementia, they have symptoms of hallucinations and dementia, and Parkinson's disease patients get Lewy body formation. They're going to have similar symptoms too. They're going to have the hallucinations and the depression. Another example would be multiple sclerosis. Both of those disorders show symptoms of rigidity and tremors. The physical exam will include range of motion without assistance. They're going to do supination and pronation. Also, a heel to shin test, tapping thumb and the pointer finger together. And abnormalities that occur when they're doing these range of motion is that they could go extremely fast and at a normal pace, and then all of a sudden they start to slow down with their range of motion. The next thing that could be done for diagnosis is striational dopamine transporter imaging scan. That determines if there is decreased levels of dopamine. Family history, which is rare, but it's to see if a patient carries a gene associated with Parkinson's disease. There could be an olfactory test, so the patient will be given sniffing sticks, and that's to detect any changes in the sense of smell. Functional magnetic resonance imaging. That's to look for decreased activity in parts of the brain that are connected to sense of smell. The image on the top shows a DAT scan. Normal scan for a healthy individual would show these comma-like structures, whereas in a Parkinson's disease patient, they'd have more of an abnormal scan where it's period-shaped. To the right shows the sniffing sticks, so they're going to be like these markers, and they're going to have the patient smell them to differentiate between odors. And the image on the bottom is showing a physical examination. She's having her hands out in a pronation range of motion. And I also wanted to point out that when Parkinson's disease patients do the heel to shin test, when they're bringing their heel from the top part of their shin down, they often can't bring it down in a straight line. It will go side to side. For the treatments, deep brain stimulation could be done. It's a surgery to where the electrical impulses released from the electrodes will stop certain parts of the brain from continuing to generate the motor symptoms. It's going to stop these abnormal activities that are occurring. There is drug therapy, levodopa. It acts like dopamine and it helps decrease symptoms of bradykinesia, slowness of movement. Amantadine is going to increase the amount of dopamine secreted by neurons, so it's going to allow people to have control over their body and their voluntary muscles. There's speech therapy, the Lee Silverman voice therapy. It helps patients to increase volume in their speech while they're talking, so they will have to say ah for as long as they can. And there's swallowing exercises to treat their dysarthria. This is just showing what deep brain stimulation surgery is like. There's going to be those electrodes on locations of the brain like the globus pallidus or subthalamic nucleus. And what they're going to do is they will send out these electrical impulses to stop these abnormal movements. And it's going to act like this pacemaker, just like how there's heart pacemakers to have your heart beat at a correct pace. But this one's going to be stopping abnormal movements. These are my references, and thank you so much for listening.